our next lecture for Dr. رولا القصوص. من دواعي سروري أن أقدم الدكتورة رولا. She was one of my colleagues in Jordan وكانت طبعا في لجنة الامتحان لبورد الأردن اللي امتحنون من سنتين. Dr. رولا is a consultant endocrinologist. She was graduated from Jordan University Medical School. She was trained in internal medicine and endocrinology at Tufts University in Boston. She joined King Hussein Center as endocrinologist in 2005 to 2013, and she established and led the thyroid cancer service at the center. And now she has her own private clinic in Amman. Her main focus on thyroid cancer and abnormalities, PCOS, and dyslipidemia and diabetes. Her lecture today about dyslipidemia and PCOS. أهلا وسهلا فيك وتفضل يا دكتور.
Thank you, the organizing committee, for inviting me to be in such a beautiful place. I'm really happy to be here in Palestine, and especially in Bethlehem. Okay, so I thought of uploading this photo because I think it's a very nice 3D photo. Okay, this is good. Thank you. So it's a very nice photo of cholesterol and the fat swimming through the blood vessels. And this actually is suitable for my talk today, which is dyslipidemia in PCOS patients. I like and I think that we endocrinologists should be tackling PCOS, because PCOS is not just about ovarian dysfunction, it's about the whole body changing. And I think the gynecologists look mainly at the ovaries and the periods, and we approach PCOS with the holistic approach. And that's why I think we need to be the first one to tackle and treat PCOS. Now, if you Google PCOS, you look and see many signs. Women worldwide have PCOS. It's linked to cancer, obesity, infertility, depression, hypothyroid. It's just everywhere. And interesting enough, September is actually the PCOS Awareness Month. Just like we have October for breast cancer and January for thyroid, we have September for PCOS. And it's an awareness month that's all over the world. And the color for the PCOS is the teal color. And everyone knows about the color for breast cancer, which is pink. The color for diabetes is blue. The color for thyroid cancer is yellow. But زنجاري زي لون الكراسي تقريبا هو teal color, teal, which is the color for the PCOS. And it's a very relaxing color. So this is because we actually see PCOS a lot in the clinics. I would like just to point a very small, it's a case or a clinic visit. So I had a 35-year-old British lady coming, she's from England, purely British lady, coming to see me with a complete picture of PCOS. She works in Jordan. She was obese, hirsute, alopecia. She had acne, amenorrhea, and acanthosis nigricans. And this is how actually PCOS patients present. They can come with visceral adiposity. They can come with disabling and annoying hirsutism. They can come with disfiguring acne and very distressing acne. And to me, the worst is androgenic alopecia, with the hair. And of course, acanthosis nigricans. And I've had mothers coming to tell me that they thought that their girls were actually dirty and they were not showering well and they had to clean them well because of the acanthosis nigricans. Well, it's unfortunate that they don't know about it. So this lady actually is a very unfortunate woman. She came in with all these symptoms. She was 35 years old, but she had no medications. And I was actually shocked for that. She said, and that's what she claimed, that she wasn't on any medical therapy, though she was diagnosed with PCOS at the age of 20. She had all these symptoms starting at the age of 20, which is typical actually. She was told in England, and maybe that's part of a place in England, they will only treat her once she decides to have babies. And I was like, so you only treat PCOS for fertility? That's the only aim for PCOS? You just want women to have children? What about the whole picture of PCOS? You're overlooking what's really hidden and what's very important when it comes to PCOS. Yeah, giving birth to children is essential, but not everyone will be able to give birth. Not everyone will get married. And I think we need to look at the woman as a person and not just a lady to have children. So for us endocrinologists, PCOS is one of the most common causes of metabolic and endocrine disorders in women. And it is something that we face in the clinic a lot. It's very common. The prevalence actually ranges from like 6 to 15% depending upon the diagnostic criteria. It's all over, the prevalence is all over, depending on the areas, depending on the race, it's very common. This is like a fact, one fact, they say 1 in 5 women of reproductive age have PCOS. WHO estimated that it affects 116 million women worldwide. That was back in 2010. And another study said it's about 18% had PCOS and 70% of them were undiagnosed. And I believe in that. When they have, well, one of the most common presentations is irregular periods. So sometimes they go to the gynecologist and the gynecologist says that, oh, they're still young, you don't have to do anything until they turn 18. Or they just tackle the period and they tell them that you go to a dermatologist to tackle their acne or to do laser for the hair. They have to look at the holistic approach for PCOS. So, and again, this is very, very, very important to note. PCOS is as bad as diabetes. It is a chronic disease. Because the first thing I'm asked by the parents or by the ladies is that, when am I going to stop the medications? It's chronic. It's for life. It's a very unpleasant one. Diabetes does not affect your shape unless you become, of course, obese, but PCOS affects everything else, outside and inside. And in addition to the many disturbing signs and symptoms of PCOS, the metabolic disturbances and changes are very well recognized features of this syndrome. PCOS is not just about only acne and hirsute and alopecia and irregular period. It's about insulin resistance, hypertension, diabetes, dyslipidemia. It's about depression. It's about poor body image, which is very, very important. It's everything. So let's talk about the metabolic changes. It's just like the metabolic syndrome, but it's even more. So you've got obesity, you've got insulin resistance, which could translate into impaired glucose tolerance, pre-diabetes and type 2 diabetes. You've got something which is very, very important at the moment, which is non-alcoholic fatty liver disease. It's not anymore NASH. This is very disabling because it could end in liver fibrosis and cirrhosis, and it's just ignored, not ignored, neglected in a way or another. Those women have obstructive sleep apnea. They can't sleep well. They have interrupted sleep. And basically, they have poor quality of sleep, poor quality of life. It affects their memory, concentration. It leads to hypertension and so forth. And last but not least is dyslipidemia. Metabolic syndrome is very common in PCOS, up to 43%. And these metabolic changes, they increase the risk of atherosclerotic cardiovascular disease. Well, in a way or another, doctors, persons, people, they think that because this is a disease that affects women, that they are not at risk for CAD. But they are at risk, and it starts early as subclinical atherosclerosis. And this increases the risk of MI by 3 to 7-fold. And just because they are, quote-unquote, younger patients, people think that, well, you don't have to check for dyslipidemia, or you could do it as an annual checkup. More important is to check for the thyroid, for example, and for the vitamins. But dyslipidemia is a very common metabolic abnormality in women. It's really common, despite the fact that they're very young. It's up to 70% women with PCOS have dyslipidemia. And insulin resistance, of course, is a key pathophysiological factor. But also obesity and, interestingly enough, hyperandrogenism, they both play a role in dyslipidemia with PCOS. Of course, they all work together in a very independent and interactive effects on dyslipidemia. So it all affects dyslipidemia. PCOS, weight gain, central adiposity, increased androgen, insulin resistance, and so forth. They all work in one circle. And this is all a vicious circle, of course, of PCOS and insulin resistance will affect subonal. So again, dyslipidemia is a killer. And so, of course, we all know that the deposition of fat starts at as young as 7 years of age, as yellow fat streaks. And then it goes on to accumulate more and more and more to block the vessels. Of course, added on it if you smoke, if you become obese, and so forth, it's with genetic predisposition, but at the end you end up blocking the vessels, you end up with MI, stents, sudden cardiac death, just name it. So that's the essence of dyslipidemia. That's what we care about, because it causes atherosclerosis. And again, though everyone talks about insulin resistance and obesity, dyslipidemia is the most persistent and a highly prevalent metabolic change, and a neglected one too. So what are the dyslipidemic effects of PCOS? You've got, well, it's very acceptable and it makes sense, high triglycerides. You have elevated LDL. We always look at the high triglycerides and then we look at the low HDL. And I have a lot of girls in their 18s and 20s with an HDL of 20s and 30s. It's very sad, it's too low. And then we look at the more hidden ones, the apolipoproteins, ApoA1, ApoC1, ApoB, and little protein, little lipoprotein. It's high. So the prevalence of having a total cholesterol that's over 200 in PCOS women is almost 35%. The prevalence of having an LDL that's over 130 is 31%. The prevalence of, this is the one study, of having an HDL that's low, below 35 is 15%. And triglycerides, they said the prevalence is over 200. I think it's even more because we see this a lot commonly. This is the straightforward abnormality. It's high in PCOS. It starts to rise in the second decade onwards. Of course, it can go up to like more than 200, like 226 milligrams. And this plays a role in the oxidative stress in PCOS. Now, triglycerides, we always look at the triglycerides and we say you need to cut down on carbs and you need to exercise. But I like to look more at the HDL, the happy cholesterol, H from happy, and that's how I tell my patients to remember it, and H should be high. And I like to look at the LDL. L in English is lethal. I tell my patients L comes from la'im, and it has to be low. So these are very important to pay attention to them. And actually, we always look and are strived by the high LDL, and we just tend to ignore the HDL or to say it's going to improve once the triglycerides go down. To me, HDL is the angel and LDL is Satan, it's the devil. So the thing is that LDL is not noted to be high in insulin-resistant cases, and that's why we don't look at it in PCOS. We just link it to insulin resistance. But LDL is high in PCOS patients because of hyperandrogenic effects. And of course, there are genetic factors, زي كل واحد فينا. But it is high because of high androgen, and it is noted to be high in all PCOS patients. And it doesn't have to be high, as we all know. It can just be abnormal. We all know that if you have two patients with the same LDL, one of 130 and the other one 130, that one of them will be at a very high risk for CAD and the other one not. Now, every time the LDL is large, it's pattern A, it's very less dense, and it's fluffy and it swims through the vessels, so it doesn't block the vessels, so it doesn't carry a risk for CAD. But if it's too small, too dense, lipid يعني, it doesn't flow through the vessels. It sticks in the vessels and it causes what we say pattern B, and that's the one that causes atherosclerosis. So in PCOS patients, they have high pattern B compared to pattern A, and that's why they're more at risk for CAD. Now, HDL, we have, of course, different classes of HDL. We have HDL2 and HDL3. Now, it's the same story. HDL2 is also large and buoyant particles, and it is the most anti-atherogenic HDL. But the thing is that low levels of HDL2 are strongly associated with CAD, and low levels of HDL2 and HDL are noted in PCOS patients. And that's why they are more at risk for CAD, because of the low protective HDL and HDL2. This is this slide of dysfunctional HDL and normal HDL. I'm okay with time? 5 minutes? Okay. So we talked about high triglycerides, high LDL, low HDL. I'm going to go through quickly the lipoproteins. Lipoproteins are proteins that bind lipids to form lipoproteins. They transport lipids through the blood. That's why they're water soluble, and they're found on the surface of lipoprotein. These are the apoproteins. So ApoC is to save time. It's high in the after we eat. When we are fasting, it's found on the triglycerides surface. But when we eat, it's released in the blood, and so it causes high clinical dyslipidemia and CAD. So because of that, it's very high in PCOS patients, and even lean PCOS patients were noted to have high ApoC1. Now, ApoA is what's found on the HDL. And HDL is linked to good particles of cholesterol. So ApoA is low in women with PCOS compared to women without PCOS. And obesity and hyperandrogenism contribute to lowering of ApoA. Lipoprotein little a, it's very variable what they say about it. Some say it's high, some say it's not high in PCOS, but it is an independent risk factor for CAD. So this is the ApoB is linked to LDL, and the ApoA is linked to HDL. ApoB يعني باختصار, ApoB, which is the potential atherogenic risk factor, it's not really change in PCOS patients. It's more the LDL particles. It is noted to be high in some studies, but مش definite as others. بينما ApoA, which is very protective, is low in PCOS patients. So, just a quick wrap up. The Androgen Excess and Polycystic Ovary Syndrome Society has recommended that women with PCOS receive a complete lipid profile fasting. And the LDL target should be below 130, زي باقي الناس, and triglycerides should be below 150. You need to start with lifestyle medications, diet and exercise, but you have to consider statins. Statins are important when the first therapy fails. Everyone knows that statins lower LDL, lowers triglycerides, increases HDL, and lowers CRP. And in one study, statins lowered the elevated male hormones. They improved LH to FSH ratio. They improved menstrual irregularities. But the thing is that, and that's very important, is that statins are contraindicated in pregnancy. And so if anyone wants to get pregnant, you need to stop it 2 to 3 months before they plan to get pregnant. America بتقول 2 months, British بيقولوا 3 months. Oh, I think it's vice versa, but you have to be very aware. Of course, you can use دايما بيسألوكم عن omega 3, alpha lipoic acid, N-acetylcysteine. But if you look up PCOS, it's about preparing the patients, communicating, overcoming the problem, and supporting the patients. So this is the chart about PCOS patients. I'm not superwoman, but I'm fighting PCOS. So close enough. And these are my citations. Thank you.
Thank you.
Thank you. We have time just for 2 questions.
Sorry? Metformin is used, okay, for what? For PCOS or dyslipidemia? Okay, my talk is about dyslipidemia and PCOS. It's not about treating PCOS. Treating PCOS is another story. Of course, metformin, it's about OCPs and aldosterone and everything, but I'm talking about dyslipidemia and PCOS. I didn't say anything about it.
Okay, we have to thank you all. Thank you very much. There's a coffee break. After 15 minutes, we come back to the...
Good morning again. This is my second talk for today. I hope you'll not be bored. The last talk, of course. And again, I would like also, again and again, to thank the organizing committee for inviting me and for such a well-arranged, well-organized, wonderful conference. And also on top of that, I would like to thank Novartis for sponsoring this lecture and for allowing me to talk about treatment in diabetes, something that I believe in it, and I follow it with all my heart. It's early treatment intensification in diabetes, and it's initiation of combination therapy. So I think that this morning is very suitable to brainstorm and to think, why would we start with early treatment intensification? Why should we be aggressive right from the start in treating diabetes? And we're all here very smart and very intellectual, so we can take it step by step and convince you with this new era of treatment. So what's good enough is that over the past 10 years, things have improved. Okay, the proportion of patients with diabetes who achieved recommended A1C, blood pressure, and LDL targets has increased. That's good. The mean A1C declined from 7.6% in the year of 2000 to 7.2, which is good, not perfect, in the year of 2007 to 2010. Still, the younger adults are not doing a very good job, and still 33 to 49% of patients do not meet the targets for glycemic control or blood pressure control or cholesterol control, and only 14% meet those targets while also avoiding smoking. So we are still not okay. So I will take you step by step to tell you that when we combine initially the therapy, we first of all achieve glycemic targets. Now, this is something that's very dear to the heart of Professor Ralph DiFronzo, which is the omnisoctin. So the hyperglycemia, when we talk about diabetes, it's not a simple rise in blood sugar. There are multiple organs involved that actually end up in elevating blood sugar. We have the brain with neurotransmitter dysfunction. We have the liver that's causing increased hepatic glucose production. We have a defect in the pancreas with decreased insulin secretion and increased glucagon secretion. We have the new incretin decrease effect. We have the fat cells. We have the kidneys with the increased glucose reabsorption, and we have the muscles with the decreased glucose uptake. So we have multiple pathogenesis stemming from multiple organs to cause hyperglycemia. So how on earth we just only tackle, for example, one problem and one organ and target that to improve blood sugar. When we look at the agents involved, like for example metformin works on the liver and the muscles, and that's it. We look at the TZDs, they work on the fat, on the liver, and some on the pancreas. Like each agent has an organ or two maximum to tackle the hyperglycemia effect. That's it. So it doesn't make sense that we would choose only one agent to tackle hyperglycemia only. And that's why I believe in what Professor DiFranzo said last night. Metformin is not enough and should not be early on. Now this shows that rosiglitazone, metformin, and glyburide, they all cause a decrease in the A1C, but it's not sustained. So you have to be very aware of what's going on. And they all preserve beta cell function, and though metformin might be the best in preserving beta cell function, it's also not sustained. So the rate of decline in those using glyburide was in decline of beta cell function was 3.4 more, and although metformin produced a more sustained effect to lower the A1C and had a less rise in A1C, but there's still a decline in the beta cell function. So it needs help, right? It should not be the only agent involved. So the thing is that if you want to achieve good glycemic targets, we need to start strong right from the start. Now we've been doing initial monotherapy for years, but we're not succeeding. There must be something wrong. So we have to start right from the start and be aggressive to achieve glycemic target, at least to target the multiple pathological defects causing hyperglycemia, not only one. Now, last night also, one of the doctors here in Palestine asked Professor DiFranzo and Professor Mohammed Abdel Ghani about clinical inertia. And this is something that is well encountered in treating hypertension and diabetes. I'll tell you now what inertia means. This is inertia, exactly. This is inertia. You can't move the object. It's resistance to movement and acceleration. We also did inertia in physics, since we all been through med school. So it is resistance to acceleration. The inertia of an object is the tendency of that object to remain at rest, or if it moves, to continue its motion. In another word, to stay in the comfort zone that we all like to stay in. It's to stay in its existing state. The tendency to do nothing. We all want to do nothing and remain unchanged. So an elephant has more inertia than a human. It is definitely harder to move an elephant than to move the human being. So what about inertia in medicine, and especially in diabetes? When applied to medicine, it is used to describe resistance to change in treatment. So it is the measurement of the resistance to therapeutic treatment for an existing medical condition. In another word, it is the difference between the medical care that could be aspired to what can actually be achieved. This is very important to note in diabetes. Inertia is failure to initiate, to start, or intensify treatment in a timely manner for people with diabetes whose health is likely to improve. It is a failure to establish appropriate targets and escalate treatment to achieve treatment goals. It's very easy for us when we see a patient. It's easier for us. The inertia doesn't have to do only with doctors, it has to do with patients. Now, when we tell a patient that the blood sugar is not okay and you have to start another medication or you have to start insulin, they all resist that. They're all, oh please doctor, just give me 3 more months. I want to diet and I want to exercise and I promise you I'll come back with blood sugar control. And you know what, it's easy for me too. It's easier rather than starting not just a new medication, it's easier when I don't start insulin. because then I'll have to treat the patient, educate him on insulin, it will take time, they'll call me back for the blood sugar readings. So in a way, it's easy for him, easy for me. I'm like, yeah, this is a good plan. Go back, go diet, which never happens, and comes back. So what we do in our practice is that the guidelines say start with diet, and then the A1C is 9. With diet, sometimes, initially, they're very, very, very excited. The A1C goes down to 7.5. And then we say, oh, that's really good. Okay, so God bless you. We'll see you back in 6 months. They come back, the A1C is up again. We start one medication. Come back, the A1C is fine. And then they go back, they leave for 6 months, 1 year, they come back with another elevated A1C. Yo-yo effect. So we keep on doing that and not adding another therapy or being late in adding therapy for years. The average is sometimes 6 to 7 years. And these are years lost from that human being. That person is being damaged and is being eaten up by diabetes because we are not acting right on top, and we're not on top of things. It seems that if you keep patients with A1C, this is one study, for 1 year, with an A1C over 7, not treating them well, at 5 years, they are at extreme risk for MI, stroke, heart failure, and composite cardiovascular events. We're just damaging their life. For them, they're okay, they're eating, they're sleeping, they're traveling, they're going to work, so they're fine. So this is how we should do it. We should be boom, boom, boom when we treat diabetes. Diet with medication, come back in 3 months, it doesn't work, you add another one, come back in 3 months, it doesn't work, you add another one. You should not be delaying treatment in order to achieve glycemic control and in order to protect the patient. It's our job to protect that patient. So in order to avoid this clinical inertia, in order to avoid this delay in action and in treatment, if we start right from the start, and we are aggressive right from the start, we are doing a good job, and we are avoiding that clinical inertia. And that's why we have to intensify treatment. And probably it's something that's very important is to think of preserving beta cell function. I tell my patients that you have inherited like maybe $20,000 to $30,000 in the bank. You need to protect that money. You need to try your best not to use them up in order to keep you going and to keep you alive. So the idea that what you need to know is that the defect in the pancreas starts years and years and years before diabetes starts. So you have impaired glucose tolerance, you have first insulin resistance, you have impaired glucose tolerance, and pre-diabetes, and then diabetes. So by the time we have diabetes, we have already lost the battle. It's not the time to start treatment. We have failed. So we all use metformin for pre-diabetes for years and years. So when the patient comes with diabetes while on metformin, metformin has failed us big time. And we have to start something else. We cannot just start metformin or keep it on metformin. We have to be very aggressive. By the time the diabetes is diagnosed, the patient has lost 80% of his beta cell function. It is already too late. What are we talking about? We've been dieting for years. I assure you, every one of us here was or is on diet or wants to be on diet. And everyone is exercising or wants to exercise. It's a failed process. And everyone wants to try metformin, has tried it in the past, his daughter, his sister, his mom. So we're losing the battle here. We have to look at the real things. And we have to start aggressive right from the start to preserve beta cell function. We already don't have money. And the thing is that diabetes is progressive. I say that diabetes is like the moth. عارفين الموth? It's like العاد بياكل خشب الأواعي when we're not aware of that. So it's even that complications, they start when patient is pre-diabetic, not just when he's got diabetes. So we need to to probably act very fast. And being early is always better than being late, right? This is one proof of what I'm saying. This is a VAT study. Thank you. The VAT study, it's about the veterans men aged around 60, diabetes for 10 years. They've been diabetic for 10 years, but very poorly controlled, A1C 9. So what they've done, they've started treatment. One arm, quite aggressive, one arm, so-and-so. By the end of the treatment, it did not really matter. And the intensive arm treatment did not show a decline in the complications because they started too late. Okay, so that's the idea, is that if you control, that's why when patients come to us and they've had diabetes for 20 years, and then you control their diabetes, and then they come back to you when the eyes are damaged, and when they have heart problems, they're like, Doctor, my A1C is perfect, how come I have complications? Because we started late. What about the damage that has been done in the past? And this actually is proven years ago by the UKPDS. And the UKPDS, they said that the difference, if you can read this, the difference in the A1C was lost after years. Like after the patients stopped the study, they followed the patients who were intensively treated before, and they had very good control in their A1C. It proved that they still continued to have a reduction in the complications, because what's built on a good base will be good forever. And so they still had this, what we call legacy effect. They inherited a very good A1C, a base for the less complications, lesser. So, so when we think about, again, intensifying therapy, we have to think that we need to achieve glycemic targets. We need to avoid this clinical inertia, and we need to preserve beta cell function. And again, by the time we see a patient with diabetes, it's already too late. The damage has been done. The complications are cooking. So we can't just in this era, in the 21st century, where we have multiple great agents to treat diabetes, we cannot just stick to one medication, just like Dr. DiFronzo said, especially if the patients have cardiovascular effects and so forth. Now, Novartis has been quite smart in trying to clarify this and establish this. This is a verified study. I don't think I'm going to talk about it, but I'm going to say that to verify if vildagliptin, metformin, early combination therapy would provide a more durable glycemic control compared with the standard of care metformin, rather than starting with metformin and then adding vildagliptin and metformin after we fail. So, you know, they have included patients from all over the cities with multiple problems, the diverse population. They have included so many centers, so many countries, so many continents. And this is what they've done. A group started on vildagliptin and metformin. A group started on placebo and metformin, and they're following that. I can't say anything about it because in 10 days, the results will be out in the ESAD in Barcelona regarding this verified study, and I'm really looking forward for that. And even if it doesn't show, we still have to work and work more to try to prove that we can't just start with one agent where we are flooded with multiple great agents. And again, if you start early, it's better. The earlier you intervene, the better is your chance to break that cycle. In union force, it's always good to be together, and one hand is not enough to clap. And thank you for listening.
Thank you very much. We have time for one or two questions.